We're going to talk about really good techniques for LEEP, because I think a lot of people are scared about this procedure. But any gynecologist, anyone has pretty much, even anyone who is a general medicine physician who has certainly done any operative procedures, has the ability to do this. I think there's much more fear than there should be. So hopefully we can go over some of the tips and tricks of this procedure and maybe alleviate some of the fear, and we'll be able to try out this. Well, we don't have patients to do LEEPs on, but we do have hot dogs or sausages. So we can do it safely and without causing any patients any risk or pain. So let's go over some of these tips or tricks. And this is a very brief lecture, and then it's really good to get hands-on experience. The first important thing about doing a LEEP is you want to do a LEEP comfortably. Now, you can do a LEEP in the hospital under general anesthesia or very heavy conscious sedation, and a lot of people feel very comfortable doing that. But I do want to say that this can be done in clinics such as these or in your office with very good local anesthesia. So the concept of using this is that you're going to do a ring block with a spinal needle, and you want to use a very small gauge spinal needle, such as a 27 gauge spinal needle. And you're going to be injecting circumferentially around the transformation zone, all the way around. You're going to inject at 4 or 5 different places around the transformation zone. Every single time you inject, you just pierce 2 or 3 millimeters, and you're going to inject a total of 5 cc's of lidocaine with epinephrine. This is going, and when you're using a very small gauge needle, you're going to have to push with some force, and that's going to cause the cervix to swell. But that's actually quite good, because it actually sort of blows up the transformation zone and makes the LEEP a lot easier. So the one thing you do want to avoid is going directly at 3 and 9 o'clock. You could hit branches of the uterine artery, and that's not terribly dangerous, but what will happen is the epinephrine in the lidocaine could give some palpitations. It's not going to cause a heart attack. It's not going to cause anything severe, but again, for the comfort of your patient, you want to avoid 3 and 9 o'clock. But you want to take your time doing this. Thank you. I come with the cervix too. So basically you're going to go around circumferentially, again, just not at 3 and 9 o'clock. You're going to just go in with very gently, maybe 2 or 3 millimeters into the stroma, and then you're going to press until you feel pretty significant resistance. You're going to see a nice wheel. And by using a very small gauge needle, you're going to have very minimal bleeding whatsoever. And you're going to work your way around the cervix to get, and it may take up to 5 minutes to do this, but please take your time, because well done infiltration gives excellent anesthesia. Our patients, when we do LEEPs, and we do LEEPs all in the outpatient setting, don't even feel it at all. If they do feel anything, you can stop and add more. But I will tell you, 95% of the time, they don't feel a thing. But again, time matters. If you just try to go zoom, 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 you're really not going to get the effect that you want. So take 3, 4, 5 minutes to infiltrate the cervix very well with lidocaine and epinephrine. You can also use a 1/4% bupivacaine or 0.5% bupivacaine as well. I won't stick myself. Again, this is really in a very important part, because preparation is going to be the success of your LEEP. Now, the next key concept of a LEEP is that cervical dysplasia is an epithelial disease. This is a disease of the epithelium. It is not a disease of cervical stroma. If it is a disease of cervical stroma, we have cervical cancer. So we're trying to treat here severe dysplasia, okay? And the important thing to know about the epithelium is that the HPV virus is is in the surface, but also can go into the glands. Of an uninfected cervix, the glands at maximum, and really maximum, are about 4 to 5 millimeters. Of an HPV infected cervix, those glands can actually go a little deeper. On average, about 7 millimeters, but they can go to 8, and occasionally you'll see one going down to a gland going down to 9 millimeters. But in general, if you're doing a LEEP that is 7 or 8 millimeters deep, you're getting all of the epithelium. You're even getting down maybe to a little bit of stroma, but you're not taking a lot of stroma. The goal here is to take the epithelium and leave the stroma. And the important reason why we want to not take the stroma are twofold. This first fold is if you take too much stroma, you would increase the risk of cervical incompetence. So in your reproductive age woman who maybe still has fertility or desired fertility, if you remove too much of the stroma, you're going to increase cervical incompetence and the risk of preterm labor. The second reason is that the thermal damage, if you go into the stroma, the thermal damage will start affecting the nerves of the cervix. Now, the cervix is triply innervated by the vagus nerve, the hypogastric nerve, and the pelvic nerve. And if you start causing damage to the nerves, there's retrograde denervation that can go up to 2, and some people have said up to 3 centimeters. So what is the problem with that? So if you denervate the cervix, it can cause pain. So they could have significant dyspareunia. And again, we certainly don't want that. It also can cause other female sexual dysfunctions, such as anorgasmia or the inability to have any sexual arousal. So it is important to not cause iatrogenic harm by doing a LEEP incorrectly. So the best way to just remove the epithelium while maintaining the stroma is to do, instead of a single big loop that goes down and basically gets the endocervix by making a nice cone, that's not what we want to do, because you're damaging a lot of stroma as you do that. Instead, what you want to do is you want to do a nice wide but shallow LEEP across the exocervix. You can go very wide. You can go very wide because you're going no more than 8 millimeters. So pick a broad, wide loop, which I'll show you, for the exocervix. You then want to do something called a top hat. And a top hat is where you just take a very narrow loop and just then go in, and the second part of the LEEP is just go down the endocervix, removing the endocervix, thereby getting all of the endocervical epithelium and all of the glands of the endocervix, but again, almost completely avoiding any damage at all to the stroma. So this is a little more advanced LEEP technique, but it really prevents iatrogenic harm. And again, the two most biggest problems of iatrogenic harm are cervical incompetence and sexual dysfunction. But in addition, a big broad loop can increase the risk of cervical stenosis and post-procedure bleeding. So we want to avoid all of those things for our patients. And again, it's sort of first do no harm. And again, the way to do that is just remove that epithelium, but leave stroma intact. I do want to say that it's especially important for women living with HIV to get adequate extension down the endocervix. We recently did a study, will be published, upcoming in Lancet. Actually, it was accepted yesterday for Lancet, that showed that of women who are living with HIV and who are HPV 16 positive, 17% of those women had endocervical CIN 3+ lesions. So even if their exocervix was completely normal, 1 in 5 of them essentially had CIN3, carcinoma in situ, or early stage cancer in the endocervix. So, and of course, we know that HPV-16 is the most common cancer, most common HPV virus. So, again, I want to emphasize, especially in women living with HIV, if you take care of them, and we also often don't know if we're taking care of women with HIV if they're not been tested, but it's especially important to get down adequate tissue in the endocervix, or removal of adequate tissue in the endocervix by using this top hat technique. Often you're just given a whole, handful of loops, and you're saying to yourself, well, which one am I going to choose? So I almost always choose the most shallow, broad one that I can find, and that is for the exocervix. And sometimes I'll even do 2 swipes across the exocervix to make sure I get all of the transformation zone. That's perfectly okay, and it's very safe. You then want to use this a narrow, deeper loop, but narrow, to go down and get the endocervical tissue. You really, really, really want to avoid these big loops if at all possible. Now, if you have a 64, 65-year-old woman with advanced disease, and she has a type 3 cervix, and obviously she's no longer of reproductive age and she's no longer sexually active, then maybe you want to be a little more aggressive with that type of loop. But again, you're increasing not just those first 2 problems, you're increasing the risk of post-procedure bleeding as well. So again, I almost never reach for one of these large aggressive loops. I almost always try to stay shallow, and you want to, again, a broad 1 or 2 sweeps across the exocervix is really important, because that way you don't have any positive margins. This is sort of just reiterating what we want to do here. These schematics are not perfect, but these deep, one of those big deep loops gets into the stroma and again causes that increase in risk. But a nice shallow leap across the exocervix with a top hat gets all of the epithelium that you're trying to get, but at the same time preventing iatrogenic harm. Again, I mentioned the triple innervation of the cervix, and again, we want to avoid retrograde denervation.